This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today, we're looking at a fascinating new study from the journal Trials titled Active Subperiosteal versus Passive Subdural 24-Hour Drainage Following Single Burr Hole Evacuation of Chronic Subdural Hematoma. Specifically, we are looking at the statistical analysis plan for the SUPERDURA trial.
This is a topic near and dear to any practicing neurosurgeon's heart. Chronic subdural hematoma, or CSSDH, is often called the bread and butter of our specialty, especially as the population ages. But Ilara, despite how common it is, it's also one of the most inconsistently managed pathologies in the field, wouldn't you say?
Absolutely. If you ask 10 different surgeons how they treat a CSSDH, you might get 10 different answers regarding irrigation, drain placement, and postoperative care. In Denmark, where this study originates, they've worked hard to standardize it. Since 2012, the Danish Chronic Subdural Hematoma Study Group, DACSUS, has established a gold standard, a single 13mm burr hole, temperate saline irrigation, and a passive subdural drain for 24 hours.
Right. And that's a very solid protocol. Their data shows a recurrence rate of around 14% and a mortality rate of about 2%. But the SUPERDURA trial is questioning a fundamental part of that, where we put the drain.
Exactly. The standard is a subdural drain, actually going under the dura. The concern there is the potential for complications. We've all seen it, or at least feared it. The drain tip causing a cortical laceration, an acute hemorrhage, or even being a nidus for an intracranial infection or a seizure focus.
It's a classic trade-off. You want the drain as close to the source as possible to prevent recurrence, but the closer you get to the brain, the higher the risk. This study is looking at active subperiosteal drainage as an alternative. For our residents listening, that means the drain sits above the burr hole, under the periosteum, using suction rather than just gravity.
Right. The hypothesis is that active subperiosteal drainage might be safer because it's extracranial, yet potentially just as effective, or perhaps more effective, at reducing recurrence by creating a continuous negative pressure environment that helps the brain expand and clears the residual fluid.
Now, this paper isn't the final results of the trial. It's the Statistical Analysis Plan, or SAP. For the junior residents out there, you might wonder why we're reviewing a plan rather than the data. Ilara, why is publishing a SAP so important for a trial like SUPERDURA?
It's all about transparency and preventing p-hacking. By publishing the exact way they intend to analyze the data before the inclusion is finished, the investigators are binding themselves to a specific methodology. It prevents them from changing the primary outcome or the statistical test later to make the results look more favorable. For a study that could change national guidelines, this level of rigor is essential.
Good point. So let's dive into the meat of it. This is a multicenter, randomized, non-inferiority trial. Why did they choose non-inferiority instead of a standard superiority trial?
That's a key distinction. The researchers aren't necessarily trying to prove that subperiosteal drainage is better at reducing recurrence. They are trying to prove that it is not unacceptably worse than the subdural drain, with the expectation that it will be safer. If the recurrence rates are roughly the same, but the subperiosteal drain has fewer surgical complications, it becomes the preferred choice.
Let's talk numbers. What is their primary outcome?
It's a composite outcome measured at 90 days. They are looking at a combination of two things, 90-day mortality and ipsilateral recurrent CSSDH that requires reoperation.
A composite outcome. That's always a bit controversial in neurosurgery. Why bundle mortality and recurrence together?
It increases the statistical power of the study. Since mortality is thankfully low, around 2%, and recurrence is higher, 14%, combining them gives a more comprehensive look at treatment failure. To show non-inferiority, they've set a margin of 7% absolute risk increase.
7%. That's a fairly bold margin. If the standard treatment has a 16% failure rate, 14% recurrence plus 2% mortality, they are saying that as long as the subperiosteal group stays under 23%, they consider it non-inferior.
Precisely. They've calculated they need 354 participants, 177 in each group, to achieve over 90% power. They're also looking at some very practical secondary outcomes, the 90-day Simplified Modified Rankin Scale Questionnaire, SMRSQ, complications specifically related to surgery, and the total length of hospitalization.
The length of stay is a big one for hospital administrators, but for us, the SMRSQ is what matters. How did the patient actually function?
I noticed they're also doing interim analyses.
Yes, they have a data safety monitoring committee that will check in after 120 and 240 participants. They'll look for safety signals or if one group is so clearly superior that it would be unethical to continue. It's a very well-designed safety net.
Let's get technical for a moment for the residents. They mention they're using blinded statisticians who will produce 2 different abstracts before the code is broken. Laura, walk us through that.
This is a best practice move. The statisticians will analyze the data as Group A and Group B. They will then write 2 different versions of the results. The steering committee looks at both and decides on the interpretation before they know which group is which. It removes the subconscious bias of trying to find a reason why your preferred method didn't work.
It really raises the bar for neurosurgical research. Now, let's think about the clinical application. If SUPERDURA shows that subperiosteal drains are non-inferior, what does that change on Monday morning in the OR?
For one, it might lower the stress level of the junior resident closing the case. Placing a subperiosteal drain is objectively simpler and carries 0 risk of direct brain parenchymal injury. If we can get the same recurrence rates without the poking the brain factor, why wouldn't we?
I agree, though I'll play devil's advocate. The active part of the subperiosteal drain, the suction, is crucial. With a subdural drain, you often rely on the brain re-expanding to push the fluid out or gravity to pull it. If the suction isn't maintained, do we risk a higher recurrence because there's no direct access to the subdural space?
That's exactly what this trial will answer. Previous smaller studies suggested that active subperiosteal drainage might actually be better because it clears the space more effectively without the risk of the drain clogging against the brain surface. But we need a large randomized trial like this to be sure.
And the timing is 24 hours for both. Some centers leave drains in for 48 or even 72 hours. Denmark has been very firm on the 24-hour mark to minimize infection risk.
Right. They are keeping everything else identical, the single 13mm burr hole, the irrigation, so that the only variable being tested is the drain type and location. It's a very clean study design.
It's worth noting the primary outcome is at 90 days. We know that CSSDH can recur late, but 90 days is generally the window where most surgical failures manifest.
And they're also looking at serious adverse events throughout the admission. I'm curious to see if there's a significant difference in postoperative seizures or infections. If the subperiosteal group has a 0% rate of drain-induced hemorrhage compared to even a 1 or 2% rate in the subdural group, that's a win for patient safety.
So for the residents listening, keep an eye on the SUPERDURA trial. The results aren't out yet. This paper just sets the stage. But this is how high-level evidence is built. We often rely on, this is how my mentor did it, but we are moving toward a more data-driven approach to even our most routine cases.
And for the medical students, this is a great example of how a statistical analysis plan is structured. It covers everything from the intention to treatment population to how they handle missing data and the specific non-inferiority margins. It's the roadmap for the trial.
Well, Ilara, I think that's a great summary of where we are with SUPERDURA. Any final thoughts before we wrap up today's episode?
Just that CSSDH is a growing challenge. As our patients get older and more of them are on anticoagulants or antiplatelets, the perfect surgical technique becomes even more vital. We need the safest, most efficient way to get these patients back to their baseline.
Well said. Thank you, Dr. Ilara, and thank you all for tuning in. We'll be following this study closely, and we'll bring you the results as soon as they are published.
Thanks for listening to the Neurosurgery Hub podcast. We'll see you in the next episode.
Class dismissed. Keep drilling.